Okay, well, thank you. Good morning to everybody. My We are going to be talking about this new technology called UrgoClean Ag, and I'm the guy on the right. I am the Vice President of Medical Affairs and Innovations, and my role is to explain the science behind these products. With me is my esteemed peer, Kara Couch. Myself, I'm a PhD biomaterial scientist, whereas Kara Couch actually saves lives. Kara, you want to introduce yourself real quick?
Thank you. That's very kind. I am a nurse practitioner. I've been working in wound care for 21 years. I'm currently the director of wound care services at George Washington University Hospital in Washington, D.C. We're a level one trauma center. I oversee all inpatient and outpatient wound care activities and do a few other things in my spare time. Pleasure to be with you.
Thank you. Kara has years of experience in all kinds of settings, and we are really privileged to have her today. Okay, so this product is meant for first time debridement of slough and also for continuous debridement. And I'll explain the concept of continuous debridement shortly. To remove slough from the wound is very important. And this is well known and evidence based that really, without removing debris from the wound, you probably are not going to heal the wound fast and well enough. So there are many ways to do it. The surgeon's knife is always very good, but sometimes simply not usable, for any number of reasons. We won't go into those, but you know what those reasons are. Traditional autolytic debridement with hydrocolloids and alginates, etc., have been used. Mechanical debridement with pads that have fibers that are slightly abrasive. Also, ultrasound type devices have been used. And this general class of stuff that you squeeze out of a tube, there's honey and there's, enzymes and so on and so forth. Each of them have problems. The sharp debridement is very effective, not always usable. Traditional autolytic debridement is known to be slow, and you need more than that. And then particularly with respect to things that you squeeze out of the tube, there's problem with stinging, the mess, the access for some of these very expensive products. So I think the field is ready for a new player, and that's what we want to do with our new type of technology. And I want to do that. We want to do that with the Clean AG. We know that in spite of removal of, let's say, a surgeon removes things with a knife, sharp debridement. We know that biofilm and slough. Slough is basically rotten tissue, and tissue, blood and plasma are also tissues by definition. And when they get denatured, meaning when the solids in those liquid tissues deposit in the wound, that's largely slough. You have a lot of fibrin in there, for example, which is a component comes from plasma. So this reformation of slough post debridement is a problem. How do you prevent it from coming back? So in order for this to happen, we must have continuous debridement. And whatever technology is being proposed must be effective. Of course, that goes without saying. Must be accessible, meaning it should be easily and rather economically available and should not be hard to use, should not be messy, should not be stinging, all that good stuff. And in fact, easy and comfortable patient quality of life and nurse quality of life in while using them is extremely important. If it's not user friendly or patient friendly, these things are hard to popularize. So the new technology that I present are the charged fibers that are present in UrgoClean AG. Now it does have silver, but silver is present pretty much as an antimicrobial barrier, just like any other silver dressing. This is a very effective and non-cytotoxic and gentle version of ionic silver, but silver doesn't do the heavy lifting in this product. If you adopt it, you would not adopt it for the silver. Rather, you would adopt it because of the very specially engineered fibers that form a gel and that remove slough. Okay. And we will talk about both slough removal and one type of slough that you don't see all the time, and that's biofilm. And this product is pretty good in removing biofilm So how does it work? As a chemist, I can tell you, I won't give you a big talk on chemistry here, but the first three bullets that you see there, steric exclusion, hydrophobic interactions, hydrogen bonds, these are present in many types of dressings, including in ErgoClean AG. And they will remove slough to some extent. But the most effective mode of action associated with this product are the electrostatic interactions. This is easy to understand. It sounds very, very, very technical, but it really is the attraction that we all know exists between positive and negative things, almost like between the north and south pole of a magnet. That's why we put a horseshoe magnet in there. This is abundantly present electrostatic interaction when you use ErgoClean AG. Now, tell you the truth, the negatively charged portions in wound dressings are also present in alginates. They are also present in carboxymethyl cellulose. In some of the dressings that you use that are gel forming, alginates are fairly gel forming. They're pretty good absorbent dressings. They also have negative charges. And I've drawn the picture, chemical picture of them, and you can see that the negative charges are quite far apart from each other. If you count the number of atoms here, and every bend is an atom, so one, two, three, four, five, six atoms between these two charges. The distance between these two charges are even higher. Number of atoms present. The charges are not densely present in these dressings. Compare that to the charge density of ErgoClean AG. Every third atom here has got a negative charge, according to the chemistry-based composition of the product. And this high charge density is what sets it apart from anything else out there. Now, I'm a chemist and a scientist, and we do things both in the lab as well as in the clinic. In the lab, you can actually show this. This is slough made from fibrin. This is man-made slough in the lab. Why do we do this? Because it's really good to control these experiments and see the difference under controlled conditions. If you make this slough and put this in a petri dish, imagining the petri dish to be the wound surface, you can pick the slough up purely by that electrostatic interaction if you use the ErgoClean AG technology compared to the CMC or the alginate. And there is one important element here, and we are fortunate in North America that we have this product called VASH. And then why is that important? They're kind of made for each other, so I'll just touch on that a little bit. The pH of the wound is very important, and as you know, alkaline wounds don't heal, and acidic wounds are associated with healing. pH neutral is 7. Something like hypochlorous acid exists only in a very mildly acidic pH range, right about here in the green spot. This is the sweet spot where you want your wound cleansing solutions and your wound to be. Now, this is the pH dissociation graph of VASH. Why do I bring it up VASH in this? You will see in a second. Okay, and this is where the pure hypochlorous acid product is. Now, here is the chemistry, long and short of it. This dressing is highly negatively charged at all times, at all times. The slough can be positive or negative. If it is in an acute wound, there is some slough or biofilm present, that could be positive, or it could be negative if it's a really chronic wound. So ErgoClean AG, we have got randomized control trials, shows that it works both in slough that is positively charged and negatively charged. Why does it work even when it is negative? Although they repel each other, the negative charges, because of the first three modes of action that I showed you here. These are present in ErgoClean AG, and they operate even if the electrostatic interaction is not working. But if you can make the electrostatic interaction work, the action of the action of ErgoClean AG is absolutely amplified because the slough is turned positive and it picks it up. Now, I believe BASH is available in your system. This is a randomized control trial results of the product versus aquacell, hydrofiber over here. And even without the use of the hypochlorous acid, you have 50% improvement in de-sloughing. And there's a huge study that has been published. This is the biggest study in silver 2,270 patients. Basically, you want to see here is significant reduction in slough and necrotic tissue. In fact, this technology is now written up in a new debridement consensus paper that was just published in April, 2 months ago. And in this, the negatively charged fibers in the dressing bond to negative positively charged regions of slough, and slough can be protonated given a positive charge with the application of a mildly acidic cleanser such as HOCl. This is written in a peer-reviewed publication. What about biofilm? Listen, biofilm chemistry is just like slough chemistry. It's a negatively charged bacteria is associated with negative charges. So of course, when you see this paper, the biofilm removal effect of UrgoClean Ag, you have 4 logs of reduction in Pseudomonas. I'm sorry, in mature MRSA, 24-hour-old MRSA. So that's the chemistry, electrostatic interaction between the positive and negative charges. And you're going to see this from a clinician's eye and purview. And so now over to Kara. Just tell me next, and I will move the slides. Please go on, Kara.
Okay, thank you. I think I can take control, actually.
Okay, go ahead and do it. Do I
So
need to give up control?
I just requested it, so we'll see. Looks like they're
Okay.
giving it to me.
Okay, go. You can do it.
Oh, it said it didn't get control. All right, never mind. I apologize. It took it out of presenter mode. We can go back to that.
Okay, I am going back. Okay,
I'm so
can you
sorry.
see? Can
Yep,
you
now
see
I
it
can see.
now?
Yep.
Okay,
Okay.
go.
All right. So, pleasure speaking with you this morning. I was just upstairs treating an inpatient and applied UrgoClean Ag on a wound. It was an 88-year-old who had fallen at home and had a lot of traumatic wounds, including fractures, and got a hematoma on her anterior tibia. So surgery drained the hematoma yesterday, and I put the UrgoClean Ag on to help with the maintenance debridement of this wound and really get through the biofilm, as this lady has, again, 88 and has very fragile skin. So we use it very commonly here. So I want to present some of the cases that we've had here over the past 8 months or so since we started using this dressing. So this first patient is a 37-year-old male who has a past medical history of paraplegia from a gunshot wound about 12 years ago, had previously had an IVC filter placed, had multiple sacral pressure ulcers and other pressure ulcers that were present on admission. He got admitted for urosepsis, but what we decided to do was use him as a controlled case study where we did several of his wounds with UrgoClean Ag and then did several wounds with standard of care. And for us, that was actually doing a wet to moist packing with hypochlorous acid. So next slide, please. This is an example of his right lateral knee. And so ignore the green dot. We use a digital imaging app that measures our wounds for color and size. And that is what the green sticker is as the reference point. So you can see there that we applied it on December 15th, and he had a kind of thickened eschar with some slough laterally there, and then left it in place for 4 days with a bordered foam, and then went back on 4 days. And you can see how gross the dressing looks, and that just tells you how effective it is at debriding away the slough here. And then replaced it with a new dressing, and the patient went on to have a very granular, improve and healing wound. You can also see the improvement in the depth with the granulation tissue there. So got that wound completely cleaned up, and so I basically don't pay much attention to what the dressing looks like. I want to see what the wound itself looks like, and it didn't require any sharp debridement from me. I do sharp debridement all the time, but the dressing was doing the work for me. So next slide here. This is the same patient. He had a wound on the anterior tibia, and again, got that cleaned up. It was very friable epithelium, which wasn't really robust, and so we wanted to get to much more robust tissue there. And you can see that, I cleaned up and got rid of the slough, and then moved him over, and only had 4 applications of the product within about 2 weeks, and then he was discharged back to a long-term care facility at that point. So again, nice and granulated. Very easy. The nurses just changed it every 3 or 4 days and placed a compress of hypochlorous acid for about 5 minutes, and then we put the UrgoClean Ag on, and then covered it with a bordered silicone foam. Next slide, please. Same patient. This wound, they actually wanted to do some debridement in the operating room, and we were actually so impressed at how much it cleaned up the slough and converted that from a really chronic pale granulation tissue to much more robust granulation tissue. They went on and grafted that wound when he went to the operating room for his sacral pressure ulcer debridement, and that went beautifully for him, and he was able to sustain that graft and not slough it. Next slide, please. This is a patient where this actually was a skin fold of a woman who was in one of our ICUs and had been sweating profusely. So kind of a moisture associated skin damage that she got, which actually devolved into an unstageable pressure injury in her skin fold there. Very painful, as you can imagine. And we were shocked at how much it cleaned up just in one day with having it in there. And it looked even better in person than that, which is why we put the pictures in, because we were surprised at how much it really converted the wound back towards healing. Next slide, please. This is another patient that has, again, multiple pressure ulcers on the lateral ankle. Sometimes what we do is we get started when you have these big eschars there, and then once everything softens up or loosens at the edges of the wound, then I go and we'll do a sharp debridement, but then I continue with the UrgoClean Ag to provide a continuous debridement on this wound. So you can see there pre and post the change in just 4 days of what the eschar looked like, and then unroofed it, and then continued to have improvement over just a couple of days. So we took the middle picture there was 4 days after we started, and then at 6 days is what you see there on the right. So again, converting these wounds to a more healable state rather than the slough and all of the bioburden that was maintained in that wound bed. Next slide. This patient is a 54-year-old male who long history of colon cancer with colectomy, ileostomy, also had a Whipple procedure, mesh, then he got desmoid tumors, and he has short gut syndrome. So he has been a patient in our hospital for months, if not going over close to a year, and it was one of those patients where the staff and the teams get really comfortable with him because he's been around so much, and we know kind of his routine, and he's fairly stable but not able to be on an outpatient basis. So I think unfortunately he started to decline functionally a little bit, and this is a patient who previously had been walking independently around the halls, and he started feeling more fatigued, and so was sitting more, wasn't ambulating as much, and he actually developed a hospital-acquired pressure ulcer, unfortunately, from that on his sacrum. So next slide, please.
Cara, one thing, can you mention if all of these wounds pre-application of UrgoClean AG and between dressing changes, were you soaking the dressing with Bash as recommended?
Yes, all of our patients, that's our standard antiseptic cleanser that we use here in the hospital for both inpatient and outpatient. So they all get a cleansing compress of about an ounce or two, depending on the size of the wound, for at least 5 minutes. I don't usually do it longer than that on the inpatient side, just simply because of the time. But on the outpatient side, they'll get 5 to 10 minutes of a soak and a compress and do wound hygiene prior to replacing the dressing.
Thank you.
So with this patient, you can see that's on the buttocks slough that was there. We had tried using medical honey. We had crosshatched the eschar. It had been, a deep tissue injury and then became an unstageable. And this is kind of where we were here, and continued to, the edges looked much better. You can see just after one application, he had much more robust granulation tissue. And then the eschar itself, the slough itself was really receding. So this is a patient that goes to the operating room a couple of times a week for his abdominal wound issues. And we said, you can't tell from this picture, but there is more of kind of a cleft wound in there. And we wanted to do an exam under anesthesia and a debridement. So we booked him for the debridement as part of one of his routine OR trips. And then, we'd started this in the interim. So he was going to the OR the next week. Next slide, please. Sorry, and that just shows after one dressing application, how quickly he improved there. And that's been our experience, that within 3 or 4 days, you get a dramatic appearance. So this is what it looked like when he went to the operating room. And I think that I lost a little bit of my credibility with the surgeon, because he looked at me like, really, you think this needs to be surgically debrided? And I said, well, it did last week. And I had to kind of save face a little bit. So like I said, at least he was going for a different reason, not just for this wound. So fortunately, he didn't have anything really deep. We did some more sharp debridement in the OR, and then reapplied the UrgoClean Ag to continue the maintenance debridement of this wound. And you can see there continued to improve after just 5 applications in about a 2-week time period. Next slide, please. Oh, so sorry. So he had 6 total applications in the 2 weeks and did really well with that overall. And then on the next slide, this is another patient of mine, African-American female with multiple medical problems. This one was where I had really kind of gotten very comfortable with the dressing, and was thought I'd spread my wings a little bit and test the limits of it and see if it could really do a difficult wound. So this poor woman had multiple medical problems: atopic dermatitis, prurigo nodularis, hypertrophic lichen planus, hypertension, lymphedema, AFib, and recurrent leg cellulitis, morbid obesity, and she had MSSA bacteremia. So she got admitted from a facility with necrotic inner thigh wounds with this multi-pathogen bacteremia. So we did a biopsy by dermatology. My thought was that it was actually non-uremic calciphylaxis. That was my working diagnosis for her. Again, that calciphylaxis can happen in people who are not on dialysis, and so we should not discount that as a possibility. And as suspected, it was a very weird infarcting type ulcer. The biopsy done by dermatology came back as either calciphylaxis versus purpura fulminans. So next slide. So this is what this poor lady looked like, with these really large inner thigh wounds, intensely painful. You can see that she, again, is morbidly obese, and the wounds were almost touching each other. So we couldn't do a whole lot, and surgery was not keen to take her to the operating room. First of all, these eschars were so hard, they weren't really opened up, and this was kind of a Pandora's box situation, where if we cut into her, we were going to make holes worse and not really have a way to treat her while we're waiting for the biopsy. So I said, well, let's try the UrgoClean Ag. She had a lot of Pseudomonas that we were treating also. You can see the Pseudomonas that's there on the dressing that's in the middle. She also had a Foley catheter and had a fecal management system to divert her from there. So next slide. Started with the UrgoClean Ag, and it really—
Sorry, which one? Is this the next slide?
Yeah, this is correct. Yep. This is correct.
Okay.
So it started with the UrgoClean Ag, and you can see that it rapidly pulled all of the eschar and the slough away from the wound. And this was centimeters thick, not millimeters thick. I just want people to understand like how deep these holes were with this lady. And you can see that we, again, just had the UrgoClean Ag and covered it with our silicone bordered foams. We changed those dressings, probably every day, the outer dressings, and left the UrgoClean Ag intact, and got it to the point where I could actually debride this at the bedside and take these large areas down. So next slide here, please. So this shows the other leg that you can see with just 3 applications, I was able to get all the tissue separation, where without giving her any anesthesia, she could tolerate that, where she never would have been able to tolerate that if I had tried to do that bedside when the eschar was still very attached. And so I could just, literally just kind of pull it back and shave it off without cutting into her, but then use the UrgoClean Ag for maintenance debridement. Next slide. This is the other leg. And so this kind of shows you the rapid progression of these wounds also, which is another clue that this was not just a typical cellulitis or things like that, where you can see these dark infarcted areas of the skin that then rapidly turned into that medial that medial thigh there. And then you continue to kind of evolve. Next slide. This is the same patient that she had it on her medial thighs, her outer thighs, and her medial calves as well. So basically all of her lower extremities, and showing the same sort of thing where this evolved over time. Again, the dressing itself looks pretty disgusting, but the wound you can tell is improving from there just with a few days. Next slide. We got this wound to get completely cleaned up, and again was able to just kind of shave off of that dark spot there, and then get it to a more of a healing state. Next slide. This is a patient of ours who, a 54-year-old male, who had a living donor-related kidney transplant and a splenectomy as a child, so had been on immunosuppressive medications for about 4 decades, gets admitted to our hospital in mixed septic and cardiogenic shock secondary to strep pneumonia. He went into DIC, he went into respiratory failure, he got trached, he was cannulated for ECMO, VA ECMO, for about 10 days, and also underwent, unfortunately, bilateral lower extremity amputation and bilateral upper extremity amputation from pressor damage. He then got shingles after all of that, as a part of his severe comorbid conditions. So we have difficulty with our ECMO decannulation sites because the French catheters are, usually 14 or 16 French when they're femorally cannulated, and we get a lot of diffuse slough and non-viable tissue in their wound beds. They usually defer debridement of those and just want us to treat them topically because of the large vessels that were there. So we thought, well, let's try using UrgoClean Ag here, and then that way it's going to be more of a gentle debridement that we don't have to worry about invading into the vessels. So that's what we did for this patient here. Next slide. So you can see over time that we got that from, it took about a month, but this was 7 applications and got everything, debrided, desloughed, and then continued to move it even with granulation. So I don't necessarily stop even if I've gotten to granulation because it's continuing to attack the biofilm that reforms on these chronic wounds. And again, I mentioned that I just did it on a lady that had a hematoma evacuation yesterday. Didn't look super sloughy, but I know she has still some non-viable debris left in that wound bed. Next slide. This is, I think, my last case, and this one is personal to me, so I like ending with this one. This is a 14-year-old child who was diagnosed with Ewing sarcoma about 9 months ago, and he is the son of one of my good friends. And he had to undergo major surgery in January where they resected, I think, 4 of his ribs. He went through 8 months of chemotherapy and needed radiation. And his mom is a physical therapist and a physician assistant who also works in wound care. And she contacted me and said, I'm so terrified that he's going to have wound healing issues with his incision. And, can I call you if something happens? And I said, of course. And he actually ended up getting his incision healed fine, but he got a wound from his chest tube insertion site that was not healing. And he had to start getting radiation therapy and go back on chemo within about 3 weeks of his surgery. So he's at a major medical facility, world renowned in the US. And they tried enzymatic debridement with collagenase santal. They tried autolytic debridement with medical honey and didn't make any moves on this wound at all. And they basically told his mom, sorry, we don't have any other tricks. And so she reached out to me. So next slide. This is what his wound looked like after he had removal of the chest tube. And it just kind of deteriorated into this really stubborn slough that we could not get removed. And this is, again, after they tried Santal, they tried honey and couldn't really get any traction on this. And he was about to start chemo, and they were worried that it was actually going to get infected because it was getting more inflamed appearing around the peri wound. Next slide. So his mom was also doing pre-soaks with Vosh with all of these dressing changes, and she was changing it basically every day, checking on it because she was so paranoid. And quite frankly, if this is my child, I think I would have done the same thing. So that just shows that after 1 week, and we'd already struggled with this for about 3 weeks, that we got this completely debrided and got rid of all of the slough. And he went on to completely heal this wound. And I'm very pleased to say that he has finished his chemo and is in remission right now. So he just got that good news about 2 weeks ago, which was amazing. So next slide. Oh, sorry, I thought I had a final, but that was basically, a huge win in his, I just couldn't be happier and that we're able to get something to help